Did you know that Mila Kunis, the Hollywood star, once battled a condition so severe it caused blindness in one eye? So she suffered from chronic iritis, a form of anterior uveitis, for years before undergoing surgery to restore her vision. So in this picture, we are going to talk about uveitis, the symptoms, causes, treatment, and why this understanding this disease is very important for medical students. So let's start. So before we talk about uveitis itself, we have to know a little bit of anatomy in order to understand the uveal tract and uveitis. So the uvea is a middle vascular layer of the eye, and it is sandwiched between outer fibrous layer, which is sclera and cornea, and inner layer, which is the neural layer and its retina. So it is comprised of three main structures. First, we have iris. So the iris is anterior part of uvea. It controls the pupil size and regulates the light that is entering into the retina. The second part of uvea is the ciliary body. So the ciliary body produces aqueous humor. This is an intraocular fluid and contains ciliary muscles which adjust the lens in the eye for accommodation. And the third part of uvea is choroid, and choroid is a posterior part of uvea. It is highly vascular and supplies nutrients to the outer retina. So now let's talk about the etiology of uveitis. So we can subdivide this into two main groups. We can have infectious causes. For example, among the viral causes, we have herpes simplex virus, cytomegalovirus, varicella zoster virus, and Epstein virus. We can have bacterial causes like tuberculosis, syphilis caused by Treponema pallidum, Lyme disease caused by Borrelia burgdorferi. We can have fungal causes, for example, histoplasmosis and candida albicans can also cause uveitis, and we can also have parasitic causes. So toxoplasmosis is another cause for uveitis. We can have non-infectious causes, and these are mostly the autoimmune diseases. So for example, sarcoidosis, ankylosing spondylitis, juvenile idiopathic arthritis, Behçet disease, rheumatoid arthritis, inflammatory bowel disease, Crohn's and ulcerative colitis, psoriatic arthritis, and also reactive arthritis are among the causes of uveitis. And note that most of these autoimmune diseases are associated with HLA-B27 histocompatibility complex 4. So this is one of the sources for diagnosis of the patient who is suffering from uveitis. Now let's talk about clinical features of uveitis. So here we are going to subdivide uveitis into two main groups. We subdivide it into anterior uveitis with its own set of clinical features, and also we are going to subdivide it into the second group, which is intermediate and posterior uveitis. So if the patient is suffering from anterior uveitis, the patient is going to have pain, and this is usually described as a deep aching pain. The patient will also have redness in the eye, and be very careful not confusing this redness with other eye conditions like conjunctivitis, which can also cause redness in the eye. Photophobia in anterior uveitis is usually due to inflammation of the iris and ciliary body, and it is hallmark of anterior uveitis. And the patient may also have tearing, which we call epiphora. But note that blurry vision is a common symptom among all types of uveitis. So if the patient is having anterior, intermediate, or posterior, or even panuveitis, the blurry vision is going to be among the symptoms. But other symptoms, pain, redness, photophobia, and epiphora are dedicated symptoms of anterior uveitis. So the second group is intermediate and posterior uveitis, and in this case, the patient is going to have painless visual disturbance, and it is more common in the patient who is suffering from posterior uveitis because painless visual disturbance is usually due to involvement of the retina and choroid. Patient may also report floaters or scotoma, but the main symptoms in intermediate and posterior uveitis is painless visual disturbance. So now let's talk about examination, and again we are subdividing uveitis into anterior uveitis and intermediate and posterior uveitis. So when the patient is having anterior uveitis, first of all you are going to see ciliary flush, and this is redness at the limbus of the eye. The patient is going to have creatic precipitates, and these are white inflammatory cells that are deposited on the corneal epithelium. Here in this picture, you can see corneal epithelium with white inflammatory deposits on its surface. The patient may have hypopyon, and hypopyon is a layered leukocytes in the anterior chamber of the eye. So here in this picture, you can see hypopyon. These are white leukocytes, white inflammatory cells deposited on the anterior chamber of the eye. And the pupillary findings here are also very important for you to know. The pupil is going to be small and irregular in shape. So instead of having a very nice and round pupil, the patient is going to have a irregular shaped pupil, something like this. And if you administrate light into the pupil, the response is going to be very sluggish, and this is very characteristic in the anterior uveitis. If the patient is suffering from intermediate or posterior uveitis, the patient may have a vitritis, which is the inflammation of the vitreous humor. So in this case, if you do fundoscopic examination, the fundoscopic examination is going to be very hazy, and it is due to the fact that we have inflammatory cells deposited in the vitreous humor. Another finding is retinal lesions, and these are white yellow patches of inflammation in the fundoscopic examination on the retina. And another finding here is choroidal thickening, which is visible on the imaging. So now let's talk about diagnosis of uveitis. So first of all, note that history here is very important, and you should be asking patient about systemic symptoms like joint pain, skin rashes, and fever. Also, travel history is here very important, and also sexual history, because the patient might be suffering from syphilis, and uveitis is secondary to syphilis, or even TV exposure. For example, if the patient is reporting joint pain or stiffness, this is very suggestive of ankylosing spondylitis or sarcoidosis. And if the patient is reporting oral or genital ulcers, this is very suggestive of Behçet disease. If the patient is reporting skin rashes, this can be due to psoriasis or reactive arthritis, another cause of uveitis. And if the patient is reporting fever, fatigue, and night sweats, these are suggestive of infectious causes like tuberculosis. So the history is here very important for you to ask from the patient. The second tool that we are going to use is a slit lamp examination, and it can detect cells and flares in the anterior chamber of the eye, and also you can see classic precipitates and synechiae in the anterior chamber. So what is the synechiae? Synechiae is plural for synetia. These are adhesions between tissue of the eye. These adhesions are not supposed to exist there, but they are now because of the inflammation and uveitis. So the third type of tools that we can use is dilated fundoscopic examination. This is usually done in order to assess the retina and choroid. Another tool that we can use for diagnosis of uveitis is tonometry. So by doing tonometry, we are measuring intraocular pressure. Recall that uveitis is a risk factor for glaucoma, so you have to do tonometry in order to be sure that if the patient is also suffering from glaucoma or not. And we also have laboratory workups, and these are usually done for diagnosis of underlying causes. So generally, what kind of laboratory workups we do? For infectious causes, PPD test for the tuberculosis, VDRL or RPR for syphilis, also serology for toxoplasmosis, IgM and IgG. For autoimmune diseases, do not forget that you have to do testings for HLA-B27 for ankylosing spondylitis, measurement of ACE level, and chest X-ray for sarcoidosis. And for other rheumatological diseases that can cause uveitis, we can do ANA and rheumatoid factors for juvenile, for example, juvenile idiopathic arthritis. We have other tests, for example, complete blood count, ESR, and CRP, which can help you to make the definitive diagnosis of underlying cause. So now let's talk about management of uveitis. So here we have several general principles. So underlying diseases must be treated, inflammation should be reduced, and complications must be prevented. So if the patient is suffering from anterior uveitis, we are usually starting with topical steroids. So prednisolone acetate 1% eye drop can be used. We can also use cycloplegics like atropine or cyclopentolate, and this is usually done in order to prevent formation of synechias and reduce the pain. So if we have a very severe anterior uveitis, we can use systemic therapy with oral steroids, but this is usually reserved for very severe cases. If the patient is suffering from intermediate or posterior uveitis, because this disease is much more serious than anterior uveitis, we are going to start with systemic corticosteroids. So prednisone is going to be used with 1 milligram per kilogram per day. For example, if the patient is weighing 80 kilograms, you are going to give 80 milligrams of prednisone for every day. Another drug that we can use are immune suppressants, and these are usually drugs that are used when we have uveitis due to autoimmune diseases. For example, methotrexate can be used, and also biologic agents like infliximab. If the causative agent is microbial, we can use antimicrobial therapy. For example, if the patient is having tuberculosis and uveitis secondary to tuberculosis, we can use antimicrobial therapy, for example, anti-TB drugs. So here you can see a case of uveitis. If you want to practice uveitis, solve this question and leave the answer in the comments. Thank you for watching.